Dr. Susan Rogers, recently retired, is a volunteer attending hospitalist and internist at John Stroger Jr. Hospital of Cook County. She previously was co-director of medical student programs for the Department of Medicine. She's an assistant professor of medicine at Rush University. Dr. Rogers received her medical degree from University of Illinois Chicago and completed her residency at Cook County Hospital, where she served as chief resident. She's a national board member of the Physicians for a National Health Program and a past co-president of Healthcare for All Illinois. Thank you, Dr. Rogers.
Thank you. Thank you for having me today. This is a topic that I am very passionate about and feel that it's about the best way to solve the problems that we have with healthcare today. I'll try to keep this within the time limit so that there's enough time for questions. But let's start out with, why do we need health insurance anyway? And there's three main reasons why we need it. One is to protect our financial assets if we get sick, or if we know we have chronic illnesses, to still protect those assets. It's also to provide access to care, because you know you can't get things done unless there is a way to get it paid for. And it's also to protect our health, to do the things that we need to do to keep being healthy. So what do we have now? Well, in this country, we have 5 major ways that we deliver health care. The most common one is for people who are under 65, where the worker or the employer share the premium, and that premium gets paid to a private insurance group. So that is health care through a private insurance. And then there is health care through Medicaid, and Medicaid covers people who have disabilities, women who are pregnant. There's a CHIP program for children, and then with certain poverty levels you can receive Medicaid. But keep in mind, before the Affordable Care Act, just because you were poor didn't mean you got Medicaid. You had to be poor and blind, or poor and pregnant. There had to be something else. And then if you're over 65, you get Medicare. And then there's the military, and there's veterans and Native Americans, and this group gets their care through what is actually, by definition, a socialized system. They get care at government buildings delivered by people who are government employees. And then there's a large group of people who have neither of those, none of those ways to get health care, and they get it whatever way they can, and they end up with statistics that are no different than what we find in third world countries. So we spend a tremendous amount of money, and you can see on this slide, this is the United States at the bottom, and we spend over twice as much as many countries spend already. And that yellow line in our bottom line, that's the amount of government dollars already going into our healthcare system. And by government dollars, I don't mean just Medicare and Medicaid, but those are the premiums that pay for my health insurance when I was a Cook County employee. It pays for all government insurance, government employees. It pays for teachers, it pays for firemen, it pays for policemen. That's a lot of people whose premiums are already paid with government dollars. And then there's an extra part, and that's what comes out of everybody's pocket. So that's what comes in to pay whatever is left to pay for the premium that your employer doesn't pay. It comes in deductibles, it comes in copays. That's our skin in the game right there. And you can see that that's a lot of money that we are required to put in to this healthcare system when the government is already paying more than what most other countries pay. And what do we get from this? Well, we don't live as long. We're actually 23rd or something like that in terms of life expectancy in the world. Interesting, though, if you look at the life expectancy of people once they get Medicare, it goes up. And that's clearly a result, I think, of access to care, of less out-of-pocket expenses. So that's, I think, a very good argument, and how Medicare for All may start that graph way at the bottom at 0. And not only do we not live as long as adults, our babies are dying. We have an infant mortality rate that is similar to a third world country. And I think even more astounding than that, women are dying while pregnant. And when we say maternal mortality, we're talking about the death of a woman who was either pregnant or within 6 weeks of delivering. Not from some accident, but something related to being pregnant. And it used to be that women die because of hemorrhage or infection, and these are something that can be taken care of within a proper setting. But now women are dying from drug abuse, from other diseases associated with that, and a lot of that is because we spent so much on health care. There's no money left for social services to address these needs in women. So, what are our challenges here? Well, I see we have 5 major challenges: access to care, choice, the benefits of that care, the quality, and the costs. So let's talk about access. Well, what the Affordable Care Act tried to do was to improve access to care, and it did that by mandating the purchase of private insurance. It subsidized premiums for people who were 400% or less of the federal poverty level, and expanded Medicaid eligibility. And it did some very good things. It covered kids up to age 26, that they could still be covered on their family policy. It prevented you not being able to be covered if you had pre-existing conditions, and it eliminated the lifetime benefits. But even in the best of terms, even with the Affordable Care Act working the way it was expected or the way it should in the best scenarios, there still would have been 30 million people without insurance. So the Affordable Care Act really never solved the problem of how do we take care of everybody. And people who are uninsured don't live as long. There's a correlation between being uninsured and whether you're going to die prematurely. So Medicaid under the Affordable Care Act did expand coverage. Expand coverage under CHIP, which is the Child Hospital, I forget the mnemonic. Yes, that's it, okay. It enhanced federal funding for benefits for adults, and it made it so that adults who were at certain poverty levels could get Medicaid even without having to be blind or having to be pregnant. It changed, that's the eligibility standards that were changed. And it also covered young adults leaving foster care. Before, when children were in foster care, once they reached age 21, they were on their own unless they were covered by their foster parents. But now they are covered until they're 26. And it did improve drug coverage for them, for everyone, through the Affordable Care Act. But even the expansion of Medicaid didn't necessarily give everybody access. Medicaid is a totally underfunded program, as are most programs that are targeted to care for poor people. And a lot of physicians would not take Medicaid patients because they were not reimbursed appropriately. If you saw only Medicaid patients, you could not survive as a physician because you wouldn't make enough money to keep your office open, let alone money in your pocket as a salary. So especially with specialty care, which tends to be more expensive than primary care, those doctors wouldn't get in Medicaid. Why should they when they can make more money seeing private insured or even Medicare? So single payer, though, everybody would be involved. Everybody would be automatically enrolled, and it would be federal guarantee. And we say all residents of the United States, not whether you're a citizen or not, whether you're a resident. And I don't know if any of you have been in Europe, for example, and needed health care there. You get your health care at the same price that everybody else who lives there, and which is much, much less. So let's talk about choice. Well, with private health insurance, there's restricted choice. And what private health insurance does is it limits the network, because that way it interferes with your ability to access to care, thus decreasing their costs. So that now you can only get your health care through doctors and hospitals who have negotiated contracts. And you pay more if you go out of network. But one of the things, you don't even know exactly who is in your network. Let's say you go to the hospital that is in your network. Chances are that ER group is not in anybody's network. ER groups tend to have a group of ER doctors that go to multiple different hospitals, and they may not be in a particular network. So you go to the emergency room for your abdominal pain, for example, and the doctor you see in the emergency room isn't in your network. And then the doctor says, well, I think you may have appendicitis, so we'll have to call a surgeon. And Dr. Smith, who was on call, is not in your network. So then you get admitted, you have all that, and you don't know any of this. You don't know this until you get home, you're feeling better, and you get bills from all these other people. And out-of-network bills tend to be phenomenally high. So this is something you can't even control. So this whole shopping around, that's good if you're buying a car. It's not good if you're sick and you need health care right away. And then you don't even know what you're shopping for. So this whole, we need to be more involved and shop around for care really is not appropriate when you're sick. And even if you're not sick, because you don't know what you need, like I said, it's not like buying a car. You know what you need in a car. Or you know what you want in a car, I'll put it though. And it's impossible to determine, like I said, what's in your plan. And even if you have insurance-based health care, you often only have one, maybe two options. I know I had only two options at Cook County, and that was either a PPO or an HMO with Blue Cross Blue Shield. No other networks. And the problem with narrowing networks is large cancer centers like MD Anderson or Sloan Kettering, they're not in networks. You can't go to those if you get diagnosed with cancer. They're not in anybody's network. A lot of academic centers are not in networks, like Northwestern, like University of Chicago, like Rush. They may not be in networks. They tend to not be because their care costs more than smaller hospitals. So those are off the table in terms of what choices you have. And Medicare Advantage, I don't know how many of you have traditional Medicare versus Medicare Advantage. Medicare Advantage is privatized. So now Medicare Advantage acts just like Blue Cross Blue Shield for people who are under 65. They're there to make money. And they may talk about, we can give you this and we can give you that. And they may offer some benefits as long as you're healthy. But then when you need something, traditional Medicare actually works better. And so what happens is that once people get sick, they leave Medicare Advantage and they go to traditional Medicare. You don't have a network in traditional Medicare like you do in Medicare Advantage. And Medicare, the overhead is much, much more. So Medicare Advantage, again, the privatization of this brings with it all the other issues that come with private insurance for everyone else. So single payer, though, would expand the choice for everybody. You could go wherever you want. Let's say I have a family member who needs something done, but they live in New York. But there's a doctor here who can do that. That family member can come here to New York, get it done here, stay with me until they get better, and then go back home. And that's true with traditional Medicare, too. But if you have a restricted network, you don't have that flexibility and that option. So single payer, it's transportable, meaning if you're in New York or California, you're covered for the same exact thing. And it's not limited to anything that's restricted. So let's talk a little bit about benefits. Well, the Affordable Care Act did improve benefits. It now said that you had these 10 essential benefits, and this included like lab care, your hospital inpatient and outpatient. It covered OB-GYN, it covered maternal care, it covered reproductive care, which they're now slashing. It covered psychiatric care, mental health care is being obliterated in this country. Physical therapy, all of that was covered under the Affordable Care Act. And one of the reasons why people who had coverage could no longer keep that coverage with their employer is because that plan did not have these essential benefits in it. And that's why they were no longer able to keep that plan. It eliminates copays and deductibles, but only on preventive services. So let's say you finally get covered under the Affordable Care Act. You haven't been to a doctor in years. You now find out you have hypertension or you have diabetes or you have something that requires follow-up care. Now you have to come out of pocket. So you're probably more stressed now. It was better not knowing you had high blood pressure. Now your pressure's really high because now you have a problem that you know you can't take care of because you can't afford to go back to the doctor. And it also stipulated that health insurance companies had to pay for at least 80% of the cost of the care for you. But what that means is that they can then, it doesn't matter. They'll just raise the premium so that they still maintain a certain revenue at 20%. So it really does not control costs. And so what happens is now people are underinsured, and the Affordable Care Act made that the norm. If you can afford, what happens is you buy a premium that you can't afford to use because you have deductibles, you have You may have a 40% pay on a hospitalization, so you would hold off going to the emergency room in case something requires you to be hospitalized. It's like having a car. I keep going back to cars, but it's like having a car without the keys to it. It's just going to sit in your driveway. Meanwhile, you're paying the monthly premium on this policy just like you're paying the monthly car note, neither of which you can use. And so most people, like I said, can't afford these out-of-pocket costs. You have deductibles that are going up, up, up. So if you can afford a $5,000 deductible, you probably wouldn't buy a bronze plan. So now you're buying a cheap plan, which has a very high deductible, so you're buying something that you can't use, and hence you're underinsured. And that's why people go bankrupt. They go bankrupt because of medical costs, and most people who do go bankrupt from medical costs had coverage at the time. So it's not because people buy too big a house or too many big screens TVs, it's because of medical bills. So single payer, though, everybody is covered for the same thing, and this makes it very appealing to the entire country as a whole, because this country doesn't like to give people who aren't in the 1% anything. So this gives everybody the same thing, the same preventive services, hospital care, everything. And one of the things it does cover is long-term care. And we have to think about long-term care. It's not just old people in nursing homes. You have children born with disabilities. You have young people who end up with disabilities. That's long-term care. It's really medical care. It's not, we call it something else, but it's still an extension of medical care. And that's what single payer will cover for everybody. And one of the advantages, too, is that that helps malpractice issues. Because rather than a physician being sued for $20 million to cover the need for long-term care for that person, it's covered by single payer. So that insurance cost isn't there. So it pays for everything medically necessary. There's no deductibles and no copays. So let's talk a little bit about quality. These things here, they're difficult to understand. They don't make any sense. I know that hospitals are penalized if patients get readmitted, but this disproportionately affects people who have social issues that interfere with their ability to do what they need to do to stay healthy. And if you have somebody who is supposed to be on a low-salt diet, but all they can afford is canned soup, they end up having to be readmitted because of the high salt. So a lot of these aren't necessarily because of poor medical care. It's all these social determinants of health, as we call them, that affect how healthy people are. But hospitals get their payments reduced for that. And there was a study done with a group of doctors from Harvard. And they were all trained with Harvard, so let's assume that they're all pretty much the same in terms of their ability to provide care. And those who took care of patients that were more minority or in lower socioeconomic groups had poor outcomes than the physicians that took care of patients who were in higher socioeconomic groups and weren't minority. So it's not a reflection of the physician, poor outcomes necessarily. A lot of it's a reflection of socioeconomic class and minority. The issue of health disparities in health care is a topic for a whole nother day that I don't really have the time to get into, but it's a real issue here, that part of which would be solved by single payer because at least it would address the access issue. So we would get improved quality with single payer. We'd have a single payer system that everybody would be acceptable with because everybody will get the quality of care. And believe me, if wealthy people would insist on having this as part of the benefit, it'll get there, and everybody will benefit from it. And it would provide continuity of care. You could keep going back to the same doctor. You could keep going back to the same hospital because there is no network that would change for you every time your insurance changes. Preventive care would be a priority. You could get mammograms. You can get colonoscopies. You can get all that without an issue. And one of the things that it would do, too, is it would enable us to create an electronic medical record that everybody could talk with. I used to work at the VA with Northwestern, and I know that if a veteran had been to a VA in California, I could access his records when he came to see me in Chicago. You can't do that now. what it is, it's the market forces. There's all these companies trying to make their electronic medical record the one, but they can't talk to each other. Even when you have systems like Advocate, each hospital still ends up kind of having their own system. So even though Advocate has a very large network of hospitals and offices, they all can't necessarily talk to each other about everything. And it also facilitates health planning by putting resources what they need in, and this is the capital investment. Right now, hospitals will try to develop resources and provide care in areas where they can make money, not necessarily in areas where it's needed. If you look at breast cancer in Chicago, for example, all of the centers to treat breast cancer that are certified by the American College of Surgeons, not a single one is in a poor minority neighborhood, not a single one. And that is because there is no money to be made in those neighborhoods. So what happens is the motivation to provide care is motivated by making money, even though clearly there are areas where there is care. So let's talk about costs. We're paying phenomenal premiums, and this bar graph shows the light blue is what it costs for a single person, the dark is for a family. So you're talking about premiums that are close to $20,000 a year, and when the employer has to increase the premium they pay for their workers, the dollars go there rather than to salaries. So worker salaries have remained pretty stagnant over the years while premiums have gone up. In addition to those premiums, co-pays, deductibles, all of that out-of-pocket expense goes up. And where does it go? It goes to healthcare profits. The pharmaceutical companies make phenomenal money. 10 years ago, and this was before there were a lot of mergers and all, the top 5 pharmaceutical companies made more money than the rest of the Fortune 500 companies combined. That's a phenomenal amount of money, and that's a phenomenal lobby that they have because they want to keep that money. And the other, where this money is going is into administrators, and it's not just, it's administrators all over. A doctor with a private office has an administrator. They often have an employee that their whole job is on the phone talking with insurance companies and hospitals, not delivering care. It's on the phone getting money. There's hospital administrators. When I trained, I'll date myself, back in 1979, I graduated from medical school. And I figured there was somebody who kept the lights on in the hospital, but I never knew what a hospital administrator was. I knew somebody had to organize stuff, but none of my friends in college, I think, had a major of hospital administration or medical administration, healthcare administration. This has just phenomenally grown, and that's where all the money is going. Their administration in this country, hospitals spend about 25% of the money they make towards administration. And this is why when you ask for an aspirin in the hospital, you see on the bill it probably costs you $50, $100, because they need to make that 25%, and they have to make enough money to cover the care that they don't get reimbursed for. And this is a quote by Huey Reinhardt, who is a economics professor in healthcare at Princeton. And he made this comment 10 years ago. There's 900 billing clerks at Duke. A billing clerk for every bed, but there is not a nurse for every bed. So this is where the money in healthcare is going. It's not going to healthcare, it's going to all of these other things. And even if you look in insurance plans, this top group these are all health insurance companies in the United States, and look at the number of employees they have per 10,000 enrollees. There may be up to 35. If you look in Canada, that has a single-payer system, they all have less than 2. It takes a lot of money, a lot of people to deny care. And these HMOs are not poor by any means. You know, if I made $60,000 a day, I would not be standing here probably. But this is the amount of money that they make. It's phenomenal. And where is it coming from? This is where the extra money from managed care Medicare goes. So who do you think pays for all those ads you see on TV for managed care? It's not the government that runs Medicare. It's the private insurance company. And those ads are not free. They're getting the money from somewhere. They're getting the money from the government that's paying those managed care companies. But the bulk of that money is now going to other things rather than health care. And what we pay for drugs. I mean, look at insulin. Insulin has been around for years and years. There have been some new insulins that have come out. But there's no reason that over 10 years your insulin costs can quadruple. And this is something people need to stay alive. And this is just a quote from the CEO of Valiant. Valiant bought this company that had 2 drugs that were in existence when I was an intern back in 1979 that were used in the intensive care unit. These were life-saving drugs. Absolutely nothing has changed with these drugs except maybe the picture on the box that it comes in. Nothing. There's been no money put into research and development, nothing. But then they tripled, 500%, I think they increased the price. And he said, because we can do whatever we want. And corporations are beholden to their shareholders. They are not beholden to who buys their product. They are not beholden to the people who need them. And they can do that. This is what market forces do. So with the Affordable Care Act, what happened was it left many of the undesirable features of private insurance still in place. Employers can still change their coverage and plans, just like on the exchange where you go to buy insurance through the Affordable Care Act. Those plans change. If you can even understand, I don't know if any of you have been to the exchange. It's like going in a nuclear power plant. I don't know my way around there, and I assume no one else does either. But it's a difficult place to navigate. You don't know what you're looking at. It's impossible to tell really what you're getting. I'm sure many of you don't even know what's in your insurance. If you broke your leg, how many visits at rehab are you covered for? You don't know, and there's no way to find out. So we're not talking about people just with life-threatening disease. We're talking about everyday things that can happen to people, and they recover, and they're fine, but they may become bankrupt because of that broken leg. And this is the reason why you have no idea what you're covered for, and it's the market forces that are driving this healthcare system, although it's shown that it does not lower costs. And what have the market forces done? Well, they've increased the number of uninsured and underinsured, decrease in our choice of doctors. Like I said, with the breast cancer centers, healthcare resources are diverted to areas where they make money rather to where they're needed. And things are unaffordable. The technology, I didn't put the slide in here, but we pay almost 10 times as much for some things as it is in Europe. For an MRI scan, could be $35 in some countries. Here it's over $1,000. And that's all because of the market. So everybody's unhappy. Patients are unhappy. Providers are unhappy. The only people that are unhappy are those CEOs making $60,000 a day, I suppose, and all the rest of the companies. So it kept the insurance industry, and it kept that's the biggest flaw. As long as it's based, it's like building a house in sand. You can do whatever you want to the roof and the walls, but you've got an awful foundation that is not going to make that house secure. But single payer, though, has real tools. The single payer program that is in the House, sponsored by Conyers, that bill, has real tools that contain costs. One, it has global budgeting, which is budgeting just like you do the fire department or the police department. Those institutions, they get X amount of dollars, and then they decide where the police go, where the fire station should be. And it's not like, well, I didn't buy fire insurance, so the firemen won't come to my house. But what does that do to the person who's next door to me who did buy it? So it makes no sense. So it all has to be globally budgeted and everything covered. The capital investment is separate from the operating costs. So hospitals get budget for their operating costs, and if they want to build something else, some cardiovascular center or breast cancer center, it has to be approved. And this way you get resources more evenly and fairly distributed. There has to be an emphasis on primary care. If you look at other countries that have universal coverage or single payer systems, there are more primary care physicians than there are specialists. In this country, it's the exact opposite. We have more specialists than we have primary care physicians. We need to be able to buy pharmaceuticals in bulk. The VA is able to bargain with the pharmaceutical companies for prices, but Congress said the insurance that we can't do that. So the VA was able to do that. We can do that too, because the thing is that we are buying the same medicine that sells for much, much less in another country. It will also decrease malpractice costs, as I said before, because of long-term care. And there's a lot of argument, well, we can't afford this, but we really can. And we would have, it will cost more, but what happens is when you read these stories about it'll cost more, they never talk about how much we will save. And I hope this slide helps you see that. We will pay more because we have to increase the Medicaid rate adjustment. So each visit per person will have to cost more. Covering the uninsured, people who now have no way of accessing care, it will cost more to cover all of those people. And the people who are in the system will utilize services more, and so that will cost more. However, we would save so much more money. The government administration of health care would be much less because there would be just one system, just one single system. Right now, government pays a lot because of managed care, because of Medicaid, because of all of these programs that are so convoluted and based in an insurance, private insurance company. We'd save money on that administration. Health Insurance Administration, all those employees that I had mentioned before to deny care wouldn't be needed. And keep in mind that those people will find other jobs. There will be some retraining, and that is in the bill sponsored by Conyers. But as with other institutions and companies, things change and people do lose jobs, but a lot of people do find other things to do. A lot of people in the healthcare industry are healthcare related. They have healthcare related skills so that they can find more jobs, because we will need to employ more people as people utilize services more. And there would be increased market power so that we can negotiate prices with pharmaceutical and device companies, and the administrative costs to providers. No longer will that provider have to spend all that time on medical records and documenting information. They won't have to hire someone in their office just to answer the phone. And the other thing, doctors can then see more patients because their time would be freed up, so that productivity would increase and new patients coming into the system would be able to be seen. When Medicare was first started back in the early 60s, and keep in mind this was before computers and all that, and everybody argued, well, all these old people are going to swamp the system. It never happened. What happens is that sometimes healthy people end up using care more often that isn't needed, and so then the doctor will just provide appointments for people who really need the care. And so it didn't disrupt the system. It didn't cause a crash in the system back then. It wouldn't cause it now. And this is exactly what happened in Canada when they instituted a national health program there, that their costs diverged. So I think this clearly shows that there is a way that having a single payer system would save money. Now, there are issues in Canada. There's issues everywhere. But I think that we have some really big issues that are just so big, we can't just say, well, that system's not perfect. It's not perfect, but it is clearly better. And this is the House bill that is sponsored in Congress now by Conyers. He first presented this bill back in 2003. So this has been for a long time. And what it has is what the Physicians for a National Health Program agree with. It's comprehensive care. Everybody has their choice of everything. There's no out-of-pocket expenses. Everybody is enrolled. It would be a progressive tax financing. And what that means is that depending upon your salary, you pay a certain percentage. But keep in mind that when I looked at my paycheck, I looked at the bottom line. How much do I get to put in the bank? And it didn't matter to me if the deduction was for a premium paid to Blue Cross Blue Shield or a tax, which would really be smaller. So even if you call it a tax, you'd be paying less. And you'd have no deductibles no co-pays, your out-of-pocket expense would be much less. So even if there is a new tax, your out-of-pocket expense is less. And that we would be able to contain costs through, like I said, through budgeting and capital planning and all of that. So the Affordable Care Act, which is based on private insurance, isn't going to solve anything, but single payer really does address the three goals that I said in the very beginning of why we need health insurance. It provides us with access to care, it controls costs and avoids personal financial disaster, which is what insurance is supposed to do, and it prevents health. It will keep us healthy. This whole idea that we should go on the market, go on the exchange, and buy a plan that we feel is right for us makes absolutely no sense when you think about it. You don't know what your health care needs are going to be tonight. You don't know what they're going to be tomorrow. You don't know what they're going to be in 6 months. You hope that they're the same, or at least not any worse. So to buy a plan that you think you need means you can predict the future. It's like, I get back to the car. I have car insurance. I hope I never have to use it, but I have it so that I don't have to come out of pocket to buy a brand new car if I total my car today. And that's the whole point of insurance, to protect the unexpected, because like I say, if you break your leg, you don't know how much rehab you're going to get. If that surgeon is in network, you don't know what your expenses will be. And no matter how careful you are, no matter how well you eat, no matter whatever, you will need health care. It's one of the things that we are all going to need. And so to ask someone to be able to decide what they need is like asking them to look in the future, because you don't know what you need. You need to be covered for everything. And so this is why we can't get a solution. These lobbies are just pouring money in. If you look at your Congress people who represent your district and see who gives them money, you'd be surprised at how much money. It used to be the NRA that was the biggest lobby. They're still big, but the healthcare industry is even bigger. So what can you do? I suggest you stay informed. You can join our group here. You can ask your congressperson to support the health bill. Now, I haven't mentioned Sanders' bill. The Physicians for National Health Program has some issues with that bill, although we do support talking about single payer. One of the things that Sanders' bill doesn't do is he doesn't eliminate all copays and deductibles. He does not provide for long-term care, which means that people who are disabled or are long-term needs, those things will not be covered. So there's some major things in our ideal healthcare, single-payer healthcare plan that are not covered in Sanders' plan. But Conyers' plan, HR 676, does cover it all. These are some, I think, excellent websites. If you ever want to go on these and get information, I think that they are very easy to use. You can search for a topic and you will find information on that. There's a lot of graphs and visuals if you like that kind of stuff, charts to see things. But there's a wealth of information out there, and I think that you'll find it a very good resource to answer questions that you may have. So I was able to stay on time here. So, oh, thank you.
When national health system was occurred in England, it was in 45, 6, or 7, all prescriptions were free. The costs were exorbitant. They put an equivalent of a $1 cost on each prescription, and it was reduced by, the use of that was reduced by 50%, a sizable amount. What do you say about that in terms of Sanders' bill, for example?
Well, clearly copays decrease usage, whether it's copay for a prescription, whether it's copay for a visit, and studies have shown, though, that copays they deter needed and unneeded care just the same. So you may not take a drug because you may not pay for it not because you don't think you need it, but because you can't afford it. And the problem is a lot of those drugs may be needed, and it will decrease usage, but
That was a nominal amount, $1.
that's true. But it still adds another step. Even if it is nominal, there are people who don't have $1. And I think that if we want to say that it's for everyone, it has to be accessible for everyone. We can say $10 isn't a lot, for a doctor's visit, but it does deter care, and that's still a big issue. And the thing is that these pharmaceutical companies are making such a phenomenal profit that the copay does nothing to cover the cost. A dollar copay does nothing to cover the cost of the drug. I don't know if any of you get your medications from Canada. And it's the same exact medicine. I get my glaucoma eye drops from Canada. And what I pay for a 3-month supply from Canada, which is in the exact same bottle from the exact same company that I would get from Walgreens, my copay is more for 1 month. So, so the drug costs are just out of hand. They're just made for profit. So I think a dollar copays never were instituted to help the bottom line. They were instituted to defer care and usage.
Yeah, so good morning, doctor. My question is about the dirty secret of hospitals about that patients who are paying with the insurance are paying for the patients who don't have any insurance, and all the services are basically written off. So how much percentage of that waste is there in hospitals? Because my brothers work in hospitals, and they know they see 5 patients, 2 of them don't pay, and the rest pay the difference. And that's why one of the costs is so expensive as well.
Yeah, that their care has to be covered. And a lot of those may be high-cost patients because they don't have insurance. They may have put off care. That's the exact reason why the University of Chicago would not have a trauma unit. A lot of those trauma patients are not covered. And those are high-cost patients. They go to the OR multiple times or on multiple men. They need intensive nursing. Those are high-cost patients. But clearly there's a need, so they chose not to provide that care, even though it's needed. And again, the choice is based on the bottom line. Whereas if you have a global budget and your institution has a trauma unit, you would have a budget that covers that care. And then we could expand trauma units, because in the middle, if you drive down in southern Illinois and you're on the highway and you have an accident, you may be 50 miles from the closest level 1 trauma unit. You can be far away even in the city of Chicago. And not all trauma patients are gunshot victims or victims of violence. I mean, we all have trauma every day. Not we all, but trauma happens every day, and people who just have accidents, people who have been in car accidents, accidents at home. So that would be covered, and that's a big problem, and that's why hospitals have all these billing clerks so that they can get money that they haven't gotten. That's why they chase not just the private pay, but people who have copays or whatever you still owe on your bill that isn't covered. And even people with insurance, if you have a bronze plan and you're admitted in the hospital and your plan only pays 40%, and keep in mind, that's 40% of covered services. So they may have done things that weren't even covered. And you've got a $50,000 bill for your pneumonia, for example, and you've got to pay 40% of that. Most people don't have that.
Hi, thanks for your talk. I also had a question about copay, but that's been touched, so I'm going to ask a different question on the capital planning, the bullet point about making capital planning in a different way. Can you update me? I'm a healthcare policy research person, and my understanding was the old certificate of need programs that are administered by states, sort of in an effort to do that, have a pretty mixed history of leading to a pretty good allocation of major capital, of big MRIs and those kinds of things. Can you kind of tell me how you see that central capital planning working in a way that does better than the old certificate of need program?
Well, it isn't It isn't working now because what happens is that certificates are often given out to, again, who grease the palms of who's ever making the decision. Well, hopefully with a single-payer system, because we would have global budgeting, that we would provide care where it's needed and not where people want it to be. Because it's clear where there are deserts. It's clear where there are medical deserts right now, even in the city of Chicago, so that those areas would be serviced first. One of the things that happens when the market forces drive development of services, you end up with too many services and too close together. And so they're all underutilized. And so in order for them to make enough money, they increase the cost of individual tests. So if you've got 5 MRI scanners within a 10-mile radius, and you've got too many scanners per the population, each scan is going to have to cost more, so each person owning that machine will make more money. So there is, I agree that there is the risk that there can be, where you pay, just like the lobbyists are giving the Congress people money, that there would be a way to grease the palms of the people who are making the decisions. But I think that hopefully it does not happen the same way. And I think there's just so many deserts, and it's not driven by the market forces, that it shouldn't be as big of a problem.
Thank you very much for the presentation. It was very depressing.
Thank you.
I have kind of 2 questions. One is, I wasn't quite clear about where the savings actually come in. If you've got big pharma that's still charging a whole lot of medicine, what is the federal program going to do? The second thing is, it's like we're all crazy. If Conyers has been promoting a plan for 14 years, what is going to change in legislatures, federal or otherwise, to make them switch their votes?
Well, this is where grassroots comes in. And I think that if you look at what's happened with all these town hall meetings, and that even if the pharmaceutical company gives me $1 million, if at my town hall meeting nobody's going to vote for me, what am I going to do with that $1 million? So it still ends up with, I think, a grassroots activity, so that they know who's voting for them, and who will vote for them and who will not vote for them. So I think that has to be grassroots. And that's what's made almost every major change that's happened in this country. There has to be a grassroots effort. And as far as pharmaceuticals go, just the way the VA decreased their costs per drug, that we would decrease our cost per drug. Why is it that they can sell the same medicine to us for 10 times more than where they sell it in Canada? And that's because we allow them to, and that the market forces allow them to. But if they want to sell it here, they're going to have to sell it for less. And they're going to want to sell it. They can't maintain their profits if they don't have the U.S. as a user. They won't.
The U.S. government's official line regarding getting drugs from Canada and that general issue is that they can't control the quality of quote imported drugs, and so this is why they enforce, at least try to enforce, restrictions on the importation of drugs from not just Canada but elsewhere. Now, how would you respond to this assertion by many in the government, and how would we be able to get around that ultimately?
I find that a very convenient excuse, because I bet half the food you all had here for breakfast came imported from some other country. We already import stuff. that we put in our bodies, our food. You can't go in the produce section without half of it being, probably more, from other countries. So we're already importing things from other countries of which we have no control over their quality. If you read stories about these shipping docks and all these things, this stuff never gets looked at. And where are drugs made now? Most of them aren't even made here in the U.S. They're made in other countries with people who work in those countries making those drugs. So I think the assumption that if I buy it from Walgreens, it's safer than if I buy it from Canada isn't based on any data. And that, you know, these drugs are not necessarily made in this country in the first place.
Yeah, this is another question sort of relating to the political will aspect, but I also want to preface it with a little personal experience because I think I'm a personal expert from being self-employed for 25 years with a pre-existing condition and trying to support medical insurance for my whole family and paying through the nose for years and changing every year or two and having different policies for different members of the family and having my kids turned down for specious reasons. But this year, my wife and I are both on Medicare. My kids both have jobs to provide medical benefits. So it's a drastic change of going from the have-not group to the apparently have group. But what struck me over all those years was that there are an awful lot of people, majority perhaps in this country, I don't know the statistics, that feel that they're in the have group. They're getting medical insurance through their employer or some way and apparently not paying much for it. They really are, but apparently not. But I wonder, is the political will there for those people who feel like they might lose something if we change the system? They might lose what they already have. And I've always felt that there was a large group of the population of America that was sort of happy enough with what they had without realizing the downsides in order to build up the political will to help what they may see as other people.
Yeah. We have to remember that most of us aren't chronic users of health care. If you look at where the dollars come from, in this country, there's 20% of the population that uses 80% and costs 80% of the health care dollars. So this is a small group of people who use the healthcare industry regularly. Most of us don't, unless something comes up and we need to go in. So unless you have a chronic illness or you have something that financially is catastrophic, most of us are unaware of medical care costs because we don't often use it. And if you look at the quartiles, 10% of the country doesn't use health care at all. The next 10% may use 0.1%. So there's a lot of people in this country that aren't regular users. Okay, if you look at young women, they may go in once a year for a pap smear and birth control, all right, which can be expensive, but they may bite the bullet and pay for it, but they're not seeing the big picture because they're not using it at high cost because of that one particular need they have. So people like you who struggled for years with that, but why does it take until Medicare with a single payer plan, now you say, yeah, this plan works. And it would have worked a lot better for you all those years, you know, and you would probably be healthier. You'd be more mentally at ease. There'd be a lot of things better if you hadn't had to deal with all those struggles. So even though there are people who may be the haves, they know people who are have-nots, and many in their family even. So it's, you know, just by saying that, and that's why on that graph, people who are over 65 who have Medicare, now their life expectancy increases. You know, that's exactly why. Because there isn't the stress from it that you have with other plans.
Hi, good morning. What's the negative aspects of a single-payer system?
I want to say none, but...
Or let's say from a practical perspective.
Yeah, no system is perfect. I mean, you've heard stories in Canada about wait times. And there may be some wait times, but right now you've got a system where some people wait forever. So there will be also some increased costs for maybe 5% of the population, even with a progressive taxation plan. So there will be some people who may end up paying more. It still doesn't necessarily address the fact that much of our health care that we provide is in urban areas. So there will be people who live in rural communities who are quite isolated from urban areas, may still have problems accessing care because they're not there. So there is no system that's perfect. But I think if you talk to people who live in a single-payer country and people who have used the system, have way fewer complaints than people who live here and have to use our system. I know that, I mean, just the out-of-pocket expenses that we're incurring that are rising are just not sustainable. And it's projected by, I think, 2025 that premiums are going to be the same as average worker's salary. And that's just not sustainable. So even though single payer may not be perfect, it is clearly better than what we have. And history has shown us, other countries have shown us that this can work.
I have a slight observation and then a question. It seems to me, in fact, it's a historical fact that there has always been opposition to social legislation. Congress, many members of Congress even opposed Social Security in the 1930s. They opposed Medicare in the 1960s, and they persist in opposing these programs which are practically unassailable in their logic and their necessity. Why then, it seems to be the main political obstacle, one of them is comments by liberal, progressive people like Hillary Clinton and Paul Krugman, the columnist, that it might be better, but it can't be attained. It's politically impossible. So this always seems to be part of the argument against any progressive legislation. I just want to know how to counter these cynics and pessimists.
Get rid of the Republic.
Well, I might add, what is the AMA's position? Where do they stand, and why don't they stand for single payer, I suppose?
Yeah. The AMA has historically been a conservative organization, and their main focus has always been on promoting private practice and the offices there, and they are not supporting single payer. To be honest, I really don't know what their official position is. But in terms of whether this is going to be attainable, there's been a lot of information. I mean, a lot of things that have happened that people have always said was unattainable. When I was born in 1953, there were 3 places my mother could go for me to be born. One was to Cook County, one was to Providence Hospital, and the other is to stay at home. Well, me and my older brother were born at Providence, and my sister was in a hurry, and she was born at home. You probably would have thought it would be unattainable for me to be standing here as a physician talking to you. So I say all that in that, yes, there are obstacles, and there are things that we could not have foreseen in the past, but we can't let that not motivate us to do the right thing. And I think eventually there will be enough people to agree that this is the right thing. Because one thing about healthcare is that it affects everybody. Unless you are totally healthy and then get hit by a train and never have used healthcare before that, you're an exception. Everybody else needs to use it. And so I think that a lot of it is trying to educate people. And a lot of it, too, is trying to convince people that just because I do this for this group doesn't mean I'm taking away from that group. And there's a quote that I've read that I really like, and it's to the privilege. Equality is like oppression. And people who have always had feel oppressed when you start talking about equality. And we have to fight against that. We have to fight against that because equality is equality, and the fact that you are privileged through no work of your own or just because of social norms isn't a reason to keep the status quo. And it's going to be hard work, just as it's been hard work to get women to vote, to get the Civil Rights Act, to get a whole lot of things done in this country. I think that this is one of them because it impacts everybody that we have to make sure we vote for, or that we work for. I found that quote on Facebook, by the way, but it to me, it is just so true. It is just so true.
I've often wondered, number one, do private insurance companies, do you think they serve any socially redeeming purpose? That's number one. And number two, you pointed out that patients who use Medicare, Medicaid, I always forget which is which, the doctors can't keep their lights on and can't make enough money to survive only seeing those patients. So I'm wondering, are people thinking about, how does it get negotiated what doctors earn or what they, how you compensate them fairly in a single payer system, pay them enough so that, 20% don't say, forget it, I'm out of here. And, without, obviously you need to be negotiating with them and keeping their costs down as well. So I'm wondering how you balance that.
Okay. For your second question, I think that what will happen is that the Medicaid rates are so low. And even Medicare rates, some doctors don't take Medicare patients because let's say they charge $100 for something and Medicare only pays $50. If they take Medicare, they can't charge you for the other $50. They can't bill you for that. By accepting Medicare patients, you accept Medicare rates. So in the increased costs would be an increase in these rates. And the way that providers would be able to increase payment, especially primary care providers, is that their time would be freed up to see more patients. So even if you see more patients, even if you get a little bit less reimbursement per patient, you're going to end up making more money. If you look at Canadian salaries, they're pretty comparable, except for some of the top percent, like some of your orthopedic surgeons, ophthalmologists, one of your higher earning medical careers, they may make a little bit less money, but I don't have a lot of sympathy for somebody who only makes $900 instead of $1 million. They should be able to still function so that physicians would still be able to come out as good, if not better, under a single payer system.
They don't have billing clerks.
Exactly. They don't have those costs in their office. They don't spend as much time on medical records and all the documentation that has to go with billing. So there's a lot of time. And believe me, when medical school, I wasn't taught to be a business person. I was taught to be a clinician. And that's what I enjoy doing. And I think that's why I like being at county so much, is because I never had to ask a patient, can you pay for this? Is this covered? I never had to ask that. And that's, I think, why I enjoy being a physician so much, is because that's what I went to school to learn to do, and that's what I continue to read on so I can continue to do it well, because that's what I like doing, and I'm not spending all this time doing other stuff, and that's why doctors are getting so burned out. And your first question, I forgot.
Private insurance companies, do they serve any redeeming social purpose?
That's a very good question. Those private insurance companies have other things in there, but even with a single-payer system, there may be a role for private insurance for things that are not necessarily medically required. So it may be some plastic surgery things, some other kind of things that people may want to have done that they can buy private insurance to cover. But it has to be that in private insurance, in a single-payer system, cannot cover any benefits that are already covered in the single-payer system. So it would be all of those medically not indicated services that people may want, that they would still be covered. And then there may be some things like, I don't know, I'm trying to think, if you look at some of the, you hear stories like from the Rehab Institute, these robotic things that come up. There may be insurance that you can buy to cover something like that may not be medically required to get a robotic, but the prosthesis would be. So there may be a role in there. And believe me, health insurance companies they are diverse. I mean, they've got a lot of hands in a lot of different things. It's not just healthcare providers providing that they do. So they will be okay, believe me.
Very interesting, thank you. My question is a little bit anecdotal. My mother has Medicaid because she doesn't work, but she's not yet 65. And she believes that that once she dies, Medicaid will be able to seize any and all assets that she has upon her death. And I'm just wondering, is that true or is she crazy? She's been giving me her jewelry. She's already started. And she put her bank account in my father's name. So I don't know what that's about.
I'm not sure of all the requirements to get Medicaid. I know to have Medicaid for pay for a nursing home, you have to have no assets, or you can put, the only thing you can maintain, I think, is your residence, so that your spouse can continue to live there or your family can continue to live there. But any other assets or cash. I don't know about jewelry because I don't know if they have a way to know that you have these things because it's not tracked by your Social Security number, whereas a bank account is. And if you have money there, they can find that. So I don't know. I don't think they can come after anything. And I know that there's rules about transferring assets. You have to do it. You can't do it the day before you think you're going to die. You have to do it, I think 3 years before. And there are like trust funds that can be set up. So if you have a pension or you get Social Security, it goes into that and then pays Medicaid, which then pays for your care, even if it doesn't cover the total thing. So I don't think she's... But I'm not an expert, so on that aspect of Medicaid, I don't know.
So you were using examples of drugs that were the same for 50 years that are going to be still available, but I can't imagine that the drug companies will keep doing research in the future if they know that they don't have the American market to pass the costs on. I'm just curious, how many people are alive today that wouldn't be alive 10 years ago because of the innovations in drugs and pharmaceuticals? So that's got to be a first-order cost of this, is that you'll slow the rate of research. Maybe it doesn't matter. Maybe we've exhausted all the stuff, but do you have any statistics on that?
I do. I think that the money that drug companies spend on research, they have highly overinflated. Most money for research comes from the NIH, which is publicly funded. We've paid for that research. We're paying for it. Drug companies then will pay for the clinical trials, which is done on people, and then they will get the drug approved, and then they can price whatever they want. All right? So they paid for these clinical trials, but they haven't really paid a lot into the research. And then where they do spend their money is on attorneys to keep that drug on patent, so that they can continue, charging whatever it is they want to spend, and without another company coming in to make a generic. So I think the pharmaceutical companies are not the underdogs here, and they will be fine, believe me. They will not go broke spending for R&D because they're not going broke now. They are spending quite a bit of money more on attorneys than they are on R&D. And it's difficult to tease it out in their annual reports. But that's where most of the money is going.
Have you, do you have any thoughts on things like tort reform on malpractice insurance and maybe convert everything over to like a workman's compensation system?
Well, I still think with malpractice, I think the long-term care coverage in a single-payer system would resolve that whole problem. And that is why OB-GYN and neurosurgeons end up paying so much more for their insurance premiums than me as a primary care doctor. Because when a baby is born, through no fault of the obstetrician, babies can be born with long-term needs. And so those would be covered by single payer. And the same with neurosurgeons. You know, when you're operating on the brain, you can have bad outcomes, and those would still be covered. So there wouldn't be any real need for tort reform. Tort reform is a double-edged sword. If you look at the history of who can sue who, there was tort reform that changed so that lawyers are now, they only get paid if they win. And that was done, that was tort reform that was done so that poor people could sue. Because before, if you couldn't pay a lawyer, no matter how badly you had been wronged, you could never sue because you didn't have the funds to pay out of pocket. So they've said, well, the attorneys will take your case, and then if you win, they take 30% or whatever it is out of the judgment. And that's one of the things that's still being done with malpractice is that, you know, these suits are filed. Even if there isn't a case, it's cheaper to settle out of court than to go to court without ever being wrong. So I think that single payer would help resolve a big, if not the whole part of it with malpractice.
Okay, last question.
This is a kind of a observation as well, but it's kind of your opinion on it is the people who make the most amount of money are the people who never see a patient, who never look a patient in the eye, never ever see someone get hurt or anything. They make the most amount of money. And I'm not saying doctors don't make money. I know that. But the thing is, compared to the percentage of what the whole healthcare cost is, it's nothing compared to what physicians make. These pharmaceuticals never see a person, never talk to a person. I've worked with insurances where I tell people in the line, talk to my patient and tell them why they can't receive. Oh, I can't talk to them. They have to call the insurance company. And they don't never get to a person. It's when it becomes a personal situation between two human beings, the money kind of like goes a little bit to the wayside. And I think should be a necessity of every CEO to look at a patient with cancer or so forth to see what that really costs.
Yeah, I mean, as long as you don't see the person, it's very easy to just deny care. That's why things are done over the phone. And I don't know if any of you have struggled with an insurance company to get something covered. It is extremely difficult. I can tell you my own story. I had a bike accident, and I fell and I broke my shoulder and I broke my jaw. And so I went in, and I didn't even realize the jaw was broken until I opened my mouth and realized it went over this way. But so then the dentist referred me to an orthodontist, and he's the one that did the x-ray, and he put the braces on to immobilize my jaw. And I ended up needing surgery later. Well, I'm still haggling with the insurance company over the $7,000 bill to pay for these braces. And I finally said, let me talk to the doctor that's denying my claim. I don't know who he is. They're not involved, and they're just, I'm speaking to someone who, I don't know, she has a high school diploma, to be honest. I don't know what her qualifications are. She's just reading what was written there. So it's not necessarily, this whole process is not necessarily fair. It's not necessarily grounded in evidence. It's not necessarily best practice. It's done at the whim of somebody who you don't know who they are nor the reason why they're doing it. And doctors are guilty too of getting involved in that. I think that, I know doctors who are unscrupulous, and that industry is rampant with that. And so that's a big problem, and I think that's one of the other things that single payer would get rid of, is that whole issue.